Firstly, I'd like to acknowledge the traditional custodians of the land. I'm coming to you today from Wurundjeri country, but want to recognise that people are coming from all different lands across Australia, and we pay our respects to elders past, present and emerging. This session is being recorded, so if you don't want your face on camera, feel free to turn your camera off. And it's my great privilege to introduce Kelly Odgen and Rheana Nation. So Kelly is a paediatric nurse. She's been working for the Epilepsy Foundation in Victoria for 8 years and is part of the education training team. And Rheana is an epilepsy support worker, social work background, and also works for Epilepsy Foundation in Victoria. So welcome. And I will pass over to these lovely ladies to take it away. Thank you.
Okay, thanks. I'll start if that's okay. Thanks Heather for the introduction. This presentation will be by myself and Rheana. So I'm going to share some slides, and so I'll just put that up now, and you will get a copy of these slides later as a PDF. So I'll just put the presentation up first. And maybe Rheana, you can give me a thumbs up if you can see it. Yep, beautiful. Yep. Okay. All right. So hopefully, Heather, you can control all the people coming in. Can you still do that, Heather?
I can do that. That's fine.
That's great. Okay. So I'll give you a little bit of background. As Heather said, I'm one of the nurses at the foundation. I'm part of the education training team. So we actually, now some people are a bit confused with Epilepsy Foundation. We're the Victorian branch of Epilepsy Australia. So we're part of the Epilepsy Smart program, and part of that program we deliver education and training all over Australia, but that might be via Zoom or it might be face-to-face. And we're doing a lot more face-to-face now, which is good. I like that. But the training that we do provide is for families, for childcare centres, preschools, schools and disability organisations. So that training might be in emergency medication, it might be in understanding epilepsy, or it might be a combination of both. So that's what I spend my days doing, and a lot of that training is very person-centred. So it's not run-of-the-mill training, it's very much incorporating a child or a person's plans, their epilepsy management plans, which I'll talk about later, and also including the family in that training. So love what I do, meet lots of people and learn a lot about epilepsy, but I'm still learning. So what I'll do today, though, is hopefully give you a bit more information about seizures and epilepsy. What I'll talk about is what a seizure is. We'll look at the diagnosis of epilepsy, the causes behind epilepsy. We'll look at the different classifications of seizures. We'll look at the different types of seizures that there are. There are over 40 types. I'm not going to go through all of them, but I'll talk about some common ones and show you some videos. I'll look at the subclinical activity that can occur and how that impacts in quality of life. I'll also talk about triggers for seizures, and we'll talk about epilepsy management. In particular, I'll talk about epilepsy management plans, which I already mentioned. Okay, so first, what is a seizure? Good question. When I actually talk to families, a lot of families, they know about seizures and what you see, but they're not always sure of what actually happens in the brain. So it's good to start with what happens normally in the brain. So normally we have chemical activity and we have electrical activity, and that's there to relay information in the brain. So the neurons communicate to each other with this activity. But in a seizure, you can have abnormal electrical activity. So that activity is very excited, and while it's in that excitable state, the brain's not able to function how it normally would. So that abnormal activity can occur any part of the brain, and it depends on whereabouts in the brain that activity is actually coming from as to what sort of seizure that person will experience. So you can imagine that's why you have so many different seizure types, because it depends on whereabouts it's coming from. So a person could have some changes in their sensations, they might have changes in their behaviours, in their movements, they might have some changes in their awareness, or they might even become unconscious. So different things happen depending on whereabouts in the brain they're having that abnormal activity. So what happens in the brain is you have a certain amount of abnormal activity, and everyone has their own threshold. So the threshold is the level at which your brain can cope with that abnormal electrical activity. And once it reaches that threshold, it actually goes past that, and you actually will see a clinical seizure. So that threshold is dependent on lots of things. Firstly, genetic. We all have our own innate threshold, but there are other things that can impact it as well. So that's why some people have seizures in some situations and not others. So if you have a look at the pictures, you can actually see the brain waves of someone who's having a seizure, and this seizure is occurring in a lot of parts of the brain. So you can see that excitability, the big peaks and spikes, and that's representing that abnormal electrical activity. Okay, but not everybody who has a seizure is diagnosed with epilepsy. So any of us could have a seizure. We all have brains, and 10% of us will have a seizure in our lifetime. But that seizure, that one-off seizure, may be due to a one-off event where there's some instability in the brain. So it might be due to a transient time where someone's unwell with an acute illness, such as meningitis. That person might have inflammation in the brain, swelling in the brain, and during that time, the seizure may be a symptom of this unstable part of the brain during their acute illness. Other examples are even in drugs and alcohol. That may be an impact of the brain that unbalances things, and so a person might have a seizure related to it doesn't even have to be the hard drugs. It could even be a reaction to a medication, but that a severe one could be a seizure. Other examples, you might have heard of febrile convulsions, and so children who have a fever, and it doesn't even need to be a high fever, but that quick change in their temperature can be, for an immature brain of a child under 7, can cause some changes. And if a person has some predisposition to having seizures, they might have a one-off seizure related to that quick change in the brain. The other conditions would be if someone had maybe diabetes and they had high or low blood sugars, that causes some metabolic or chemical changes in the brain. So a person might have a seizure there. And the last example, I've got so many examples, but the last one would be maybe in pregnancy, in preeclampsia. A person with preeclampsia has high blood pressure, and that causes some changes in the body, and they can be very unwell with that. So a symptom of that could be they could have a seizure because of their preeclampsia. So there's a lot of medical conditions that you might have a seizure related to that medical condition. It might be during that unstable stage, but it doesn't mean that that person actually has epilepsy. Epilepsy itself is an ongoing seizure disorder. So a person needs to have usually 2 or more seizures for them to look into the diagnosis of epilepsy. But there are some conditions that they know that epilepsy is part of that actual medical condition. So even one seizure might be enough for some people to get that diagnosis of epilepsy, because they know that's actually part of their condition. So you can see that any of us could have a seizure, but not everybody has that diagnosis of epilepsy. It's actually stats there. It's actually about 1/3 of people who actually do have their first seizure will go on with the diagnosis of epilepsy. So what are the causes? Why people have epilepsy? So I'll actually look at this table here, and we can look at the causes and divide them up in structural causes or genetic causes. They actually know that 60% of people know the cause of their epilepsy, but 40% of people don't. So I'm sure a lot of you are aware that the more that you know about the underlying cause, that can really help in the type of treatments for epilepsy. They say that a lot of the causes are genetic, and genetic, I mean, is something that is inherited from the family, or it could be a brand new mutation in a gene, and so that's called a de novo mutation, and that mutation might occur on more than one gene, or it might be on different parts of a gene. There's actually 400 genes that can be contributed to an epilepsy diagnosis, so there's still a lot more I'm sure to be discovered, and so there's a lot of that. 40% of people who don't know their diagnosis may be contributed to an unknown gene. But genetic changes can cause changes in the brain structurally, but it can also cause changes in the person metabolically. And a symptom metabolically for the brain could be seizures. So you can see even in the newborn phase that genetic causes may result in those abnormal development of the brain or the actual metabolic conditions. And then we can I'll look at the other parts of the, we'll stick with genetic, but other conditions such as Rett's syndrome, you may have heard of Rett syndrome, that Rett's syndrome may not even be diagnosed until childhood, into maybe in the toddler years, where the first signs of neurological changes occur, and maybe they have their first seizures as a young child, and then they look into a diagnosis there. So some of these disorders don't even start being expressed until in that childhood stage. And then in the abnormal brain development, that could even happen in adulthood. You may even have an abnormal brain development, such as cortical dysplasia, but the symptoms may not have even been known until you have your first seizure, and then they've done some investigations and they see that there is some actual structural changes there. So at any stage, we could get that diagnosis with a genetic cause. So the structural causes can be resulting, as we just said, of a genetic mutation, or it could be of an acquired structural change. So those acquired structural changes may occur in birth, where someone may have had some birth injury, so they may have had lack of oxygen and caused some damage to the brain there, and that causes some structural changes. So they're a bit like roadblocks in that normal communication with the brain pathways. Also, even in utero, mother may have been unwell, maybe with an infection, or the mother may have even been having drugs and alcohol, and that may have impacted in the development of the brain as well. So moving along in childhood, unfortunately, my pediatric background, I've seen a lot of things happening for kids where their brain has been impacted, and that has caused some ongoing structural changes. So infections like encephalitis or meningitis can cause some scar tissuing, which may be the underlying cause for the seizures, and head trauma and brain tumours, acquired brain injury from accidents as well. And sometimes the structural cause might be part of there might be a thing, I'm trying to think of it, capillaries, or the veins of the brain may have some abnormalities. It's a word I've just lost. They're not coming to my brain, but there might have some structures there, changes there as well. In adults, again, unfortunately, things can happen with your brain. You may have been involved in some trauma, tumours or infection as well. And as you get older, there's some more prevalence of people having strokes and acquired brain injury, and also Alzheimer's. There's a big correlation with epilepsy and Alzheimer's with the degenerative changes of the brain. So they're the different stages of the causes, and that's the two sort of types, is a structural and genetic. So it's always really good to know a person can have epilepsy, but we can have so many different underlying causes as why as to that person actually has epilepsy. So that's what I'm learning about every day. I always find out with that underlying cause about someone's their other medical conditions. So how do we actually classify seizures? So seizures are classified according to whereabouts that abnormal electrical activity starts in the brain. So you can have seizures where they start in one part of the brain, and they're called focal seizures. So focal seizures will result in certain things being changed in that abnormal part. So certain changes in the brain, which will cause some abnormality in the function. The other type are generalized seizures. So that's where the abnormal activity occurs in both parts of the brain, both hemispheres of the brain, and there's usually a lot more parts of the person's brain function that's impacted. They're often unconscious in those seizures as well. And a person can actually start off with a focal seizure, and they can spread and become a generalized seizure. So that's a focal to bilateral tonic-clonic seizure, if you've heard of that before. And then there are some people who are still in their journey of trying to work out where that abnormal electrical activity is occurring from. So they're often in that unknown onset area. So until they can get more information as to where their seizures are coming from, then it can be really hard to give specific targeted treatment. So the more that we know where they're coming from, and as part of that diagnosis, then the better outcomes we can get for treatment. So I'll talk about what the seizures actually look like in those different areas. So for focal seizures, the next area of classification is looking at a person's awareness or their conscious state. So a person can have focal seizures, and focal, before I forget to say, focal seizures used to be called partial seizures. So you may have heard that before, but they're nowadays called focal. And if they have awareness, the person can totally tell you what's going on. So in the past, they used to be called auras or maybe warnings, but there is actual changes to the electrical activity in the brain. So they are actually having a seizure, but they may experience some unusual things, and they can actually tell you about it. So they might experience some changes maybe in their taste. They might have maybe a feeling of being really nauseous. They might have even some throat constriction. They might even have just funny feelings in their head, maybe dizzy feelings. Or they might even have some movement. So they might have some twitches in the face or in the arm, but they're fully aware. They're able to tell you what they're experiencing. And for people who are non-verbal or little children, if they experience a focal seizure with awareness, often they might look really scared, or they might suddenly try and grab your attention. They'll grab your arm, or they might suddenly go towards an adult. And so you think, oh, something's going on here, and maybe they know that something's happening. Sometimes these seizures can just be on their own, or sometimes they can be prior to another seizure type. So particularly if you know that they could be before another seizure type, it's really good to sort of pick it up early and then be able to get that person safe before they go into the next seizure type. So you're prepared for if they have some change in their awareness. Yeah, so if maybe later on we can talk about the different things that you might know about what people experience with focal seizures. But there are some of the things that might not always be an actual motor thing or a physical thing. They might just have a funny sensation as well. So I've got a video to show you, and it's got no audio on it, but this lady has a focal seizure, and you'll see some twitching in her face, and you'll see her arm go rigid. But if you were to talk to her, she'd be able to tell you the words that you've said and exactly what's happened. She's had no change in her awareness. Her eyes are closed, but that doesn't mean to say that she's had some change in her awareness. And sometimes it can be very quick, this stage, and then move on into the next seizure, or they might just happen on their own. Okay, so that's a focal aware seizure. So the next type I'll talk about is a focal with impaired awareness. They used to be called complex partial seizures. The other ones used to be called simple partial seizures. But now it's exactly what's in its name. The focal tells you what part of the brain, and this part tells you that there is some impaired awareness. So that means that the person's not able to respond how they normally would. So they might not be able to speak to you, and if they did, they might not even make sense. They might be saying some random words, or they might be muttering in what they're saying, or it just doesn't make sense. It's not in context to what they're saying as to what's actually happening around them. They might even be walking around. You can be walking around with a focal impaired aware seizure, but it might look like for the outsider that they're walking around and they're ignoring you. If you talk to them, it might look like that they're staring straight past you. And if you to look at them, they might even, I'm just showing you lots of different examples, their eyes might be altered. They might even have their eyes deviated to one side. They might even have some drooling, for example. They might even be doing some unusual things, some unusual behaviours. So they might even be starting to take their clothes off, or doing some repetitive things over and over again, like picking at their clothes. They might even do some automatisms, which are involuntary, non-purposeful movements. So it might be like lip smacking or chewing or sucking, and there's no purpose behind it. They're just doing that over and over again. And so if you were to talk to that person, they might hear what you're saying. It might even sound unusual to them, but they may not be able to respond how they normally would. So it's really important that while a person's having a vocally impaired aware, that we're talking to them and reassuring them, because we don't want to be saying things and panicking around them because they're hearing what you're saying. Most likely they can hear what you're saying, but they can't respond. So that's really important there. And the other thing is that some people, they can be guided during their vocally impaired aware. So you might be able to get them to sit down and be in a safe place. Others won't be able to sort of go with guidance, or that they might, if you went in their face, they might actually get very aggressive. So it's important just to stay around and be there with them during the seizure, not to hold them down. I remember one family, in training last week, the ambulance operator was insisting that they hold them down in recovery position, but that was not the type of seizure that they were having. So it's really important that you just keep them safe and away from, other people and, sharp areas and steps and things like that, but you don't need to hold them down. And then, as I said, if someone who didn't understand seizures saw this person, they might actually mistake them for something else. They might even misunderstand and think that that person might have been under the influence of drugs or alcohol, or they might even think that they're having some sort of psychotic episode. So it's really important that we educate people, and we often have to educate paramedics as well, as to let them know this is actually seizure activity, and also to understand what happens after these seizures as well, because after these seizures, in the postictal stage, the brain can take a little while to sort of settle down, and the person might be quite tired, they might be quite confused, they might even be quite agitated and get very emotional, and that could be even quite aggressive. So it's really important that we let other people know that they need that space and they need that time to recover, and that they're in a safe place while they do that as well. So I'll give you a video on that sort of seizure. So this lady has some staring and some of those automatisms, so those abnormal mouth movements. They're repetitive over and over again. And she's also doing this repetitive hand movement and rocking, upper body rocking too. So that's quite different to what people in the media often think what a seizure can look like. So it's important to when you relay information about what the seizure looks like, is to try, not so much try and name it, but to identify what you're actually seeing, and definitely talk about the state of consciousness and how well that person was able to respond. And it's also helpful to talk about what their recovery was like as well, and that can be helpful information for the doctors. So the next type, the classification we'll talk about, is generalized seizures. So remember, you can actually start off with a focal seizure, and it may even spread and become generalized. So they're focal to bilateral tonic-clonic seizures. And that can be sort of take a bit longer to get to that stage. But some people can have just spontaneous generalized seizures, and a lot of the time when that happens, they are spontaneous and they're very quick. And unfortunately, there's a lot of potential for injury for those sort of seizures because they are so sudden. So the different examples of generalized seizures are, firstly, I'll talk about absent seizures. So often people say absence when they know that person's having a seizure and they're staring, but be really mindful not to call every seizure with staring an absent seizure, because remember I said before, in focal seizures a person can be staring in those as well, but they often happen for a lot longer than a few seconds. But in absent seizures, there's generalized activity in the brain, so both hemispheres have that abnormal activity. They're less than 10 seconds, and they begin very quickly, and they're easily missed because they're so quick. And so what happens is a person suddenly stops what they're doing. It's almost like they're frozen in what they're doing. Their whole face can change, their whole expression can change, and then 10 seconds, 20 seconds later, they get back to what they were doing. And so they don't actually have any of that postictal or post-seizure behavior and confusion. Often they're able to get back to what they were doing very quickly. So you can see why it's easily missed. If you're not looking at that person, then you may even miss them. So I'll give you a little video here. So this is a little boy who's answering a question in class, and suddenly he has a seizure, and you can see there's a little bit of eyebrow movement. Sometimes the eyes can flicker a little bit, and maybe even the eyes might even shut. But you can see how quick it is, and he gets back to what he was doing before and answering the question. So they're the typical absence seizures. They're quite quick. Actually, if I was to ask you, I would have asked you what's the other name for those seizures. So a lot of people have heard of petit mal seizures. So that's a layman's term for an absent seizure. So, but we call them absence. So I'll talk about the next type of generalized atonic seizures. So they're part of what you might call drop seizures. So they're very sudden. An atonic seizure means that the person has absence of tone. That's the atonic. So they go very floppy very quickly. So if they were walking, they suddenly would lose all their tone, and they often would fall forward. And because it's so spontaneous, there's often a high potential for injury, and a person may have a lot of facial injuries if they don't have good control with these sort of seizures. So it's really helpful to have some sort of helmet to help protect the head if there isn't good control with those seizures. And if a person was sitting down, it might look like they're just doing head nods like that, because they're very quick and their recovery is very quick. But it's really important for the carers to make sure that, particularly to check their head and to check that they haven't had any other injuries. So here's an example of a little boy having a atonic or drop seizure sitting up, and it just looks like he's sort of having an extra long nod really into his work. So he will recover pretty quickly and get back to what he's doing. So another type of drop seizure is a tonic seizure. So tonic is talking about the stiffness. So if a person has a tonic seizure, their muscles go very rigid. And if they were standing, they actually will fall, because every single muscle in a tonic seizure goes tight. Sometimes you might even hear a noise, because the diaphragm is a muscle as well. And that suddenly going stiff can cause a bit of a vocal noise as well. And the person often falls back and they can hit their head. So again, another big potential for injury there, and a good idea to wear a helmet if it's tolerated. As I said, they're very quick. So the seizure itself is quick, but there is potential for injury. So needing to make sure that the person's all right afterwards. But tonic can also describe the type of movement. You can have tonic movement. So some people have tonic movements in their sleep, or even during the day as part of their seizures. It's actually quite common for people to have seizures as they're going into sleep or as they're going out of sleep. So that can be a common time. So sometimes you wouldn't even know that a person's having a tonic seizure unless you're in the room with them and you're maybe sleeping with them, and you can feel that they're having those rigidities in the tonic seizures. So I'll show you the example of this little boy at night. He has a tonic seizure. And this wouldn't be picked up on an alert mat, and we'll talk about that later with Rheana, but because it's a one-off movement, he's rigid at that moment, and then his eyes were actually open because it's part of the eyes. The muscles are actually making his eyes open. He's not actually conscious at that time. So it's very quick, and it can, a person can have many of them without them even being witnessed. Okay, so myoclonic seizures. Myoclonic seizures occur during the day. They're very quick jerks, sudden like jolts. And you may have even, this is not a myoclonic seizure, but you may have had a myoclonic jerk as you've gone to sleep at night, and you suddenly go like that, and you realize, and you sort of feel like you're falling out of bed, and that's a myoclonic jerk. But a person who has them during the day, they often occur in clusters. They often occur in the mornings as well. And they're conscious at that stage, but it's a big potential for injury. And sometimes it can be mistaken as being clumsy and maybe, tripping up a lot, or they might even be, often there's a myoclonic syndrome that can occur in adolescence, and they might be putting on their makeup and they're missing their eyes or their mouth a lot, and they're trying to eat their breakfast and they keep missing their mouth. So that can be the signs that they may have been experiencing myoclonic seizures. And for some people, it's an internal experience. It's like electric shocks that they can feel, but the rest of people can't see what's actually happening. So it's very disruptive for their day. So you can see in this video what they can look like. So this lady's holding a cup of tea, so potentially a big danger there when she has the myoclonic jerk. And you can imagine trying to cross the road or going up steps and things like that. There's increased potential for injury there too. Okay, so the last one we'll talk about is tonic-clonic seizures. So that's the type of seizure that a lot of people know about. That's often the one that's in the media. So they're also called convulsive seizures, or they used to be called grand mal seizures. You might have it heard as grand mal. So I'll describe what happens during the tonic-clonic seizure. I'll break it up first in the tonic phase of the seizure. So remember, tonic is a stiffening phase. So that often what happens at the start, and if a person is standing, they will fall. And if it's a sudden tonic-clonic seizure, it hasn't come from as a post-focal, if it hasn't been spread from a focal, it will appear very sudden. So they may suddenly fall, and part of that stiffening of the muscles, their diaphragm may suddenly be very tight, and they might actually make a noise because all that air in their lungs has come whooshing out, so that you may hear a strange sort of crying noise at the start of that seizure. They also might have some changes in their colour, so they may, the diaphragm, the stiffening, they might actually go a little bit blue around the lips. But then they go into that clonic phase, and so that's the jerking phase. So in that time, all the muscles are jerking. It can look like little twitches for some people, others it can be big, strong movements. But what actually happens is also the sphincters aren't doing their job as well. So they may be incontinent, they might vomit, and often they have a lot of saliva as well. And a lot of people say it looks like froth, but it's actually just excess saliva. They might even, in that tonic phase, going back to the tonic phase, clench down, and they might actually bite their teeth or their bite their tongue or their cheek. So they might have a bit of blood in their saliva as well. So it can be, if you've never seen a tonic-clonic seizure, it can be very scary, and it's even confronting. It doesn't matter how many times you see someone having a tonic-clonic seizure, it's very scary. And especially also because you see the breathing has changed, because your normal rhythmic movements are affected. So the diaphragm's in this sort of mode doing this. So you'll see often some changes in the breathing and hear the breathing to be quite noisy. But most of these tonic-clonic seizures stop on their own, which is good, that they can feel like that they're going on for a long time. But if they go past 5 minutes, they're named as prolonged seizures. So once someone has a prolonged seizure at 5 minutes, and it's harder to stop them. So often people have had history of prolonged tonic-clonic seizures will be ordered emergency medication to get control of them in the community. So if you have not seen a tonic-clonic seizure before, this is a video just to show you the movements, that they're quite symmetrical. Both sides are affected, and this is an awful one to show for first aid reasons. We should be trying to put the person on their side, because if they, if they vomit, they've got lots of saliva, they're not able to maintain their airway when they're having a seizure, because they're unconscious and their muscles aren't keeping their tongue forward. So we must try and get them onto their side as soon as we can to prevent any aspiration. So you can see it slows down as it goes on, and often towards the end of a tonic-clonic, you might hear someone take a big breath as the muscles start to relax as well. And for some people, it's not even that as intense. It might actually be very, very subtle little shudder. For others, it can be very, very violent, and it might be very hard to even try and get them on their side, but you do the best you can. So I'll talk about subclinical activities. So we talked about the abnormal electrical activity in the brain, and that can be shown on an EEG. And some people have this abnormal electrical activity in between their clinical seizures, and that's called interictal discharges. So from the outside, you can't see any seizure actually happening, but it's still affecting the brain function. So this is something that we really talk about when we do our education in disability area as well as in schools, to understand that sometimes this abnormal activity can really impact on that person's everyday quality of life. So that abnormal that abnormal discharges can be affecting that person's attention. It might make them quite not as alert as they normally would be. They might want to sleep more. They also may have some memory impacts and learning impacts because of this abnormal activity. And some people have it all the time. Some people have it maybe building up towards an actual clinical seizure. So they have a bit of a build up. And often I hear families say that they notice that their person's very agitated prior to a seizure, or they might be just being a real poo, and they're just like, I can tell he's going to have a seizure. So that's that abnormal interictal discharges building up towards that seizure. So these subclinical seizures can be actually treated pharmacological, so with medication. They also can be treated non-pharmacological treatments as well as surgery. So the idea is that we hopefully get seizure control, but it's even better if we can also help with some reducing some of those interictal discharges. We'll talk about triggers now. So triggers are things that potentially could increase the chance of a person having a seizure. So they're things that lower that seizure threshold. As we said earlier on, everyone has their own seizure threshold genetically, but there are things that they might have a breakthrough seizure if their threshold is lowered. But not everybody knows about any particular triggers. It might be just very random for them to have seizures. So it's a good idea to notice what happens prior to a seizure and to have a diary to write down the circumstances, so you can get a bit of an idea between you and the neurologist as to whether there may be some triggers and some patterns and things that you can actually notice that you could maybe put in place to reduce triggers and maybe even prevent the seizures. So the common ones that we talk about, firstly, is if someone is unwell. So if they're unwell, they might have a virus, or they might even have a bacterial infection. They might have a fever. All those things can lower the threshold, and they might have a seizure when they're unwell. Tiredness can be a big trigger as well, so sleep deprivation. So it's really important that there's some routines for sleep hygiene. And the other big one is missed medication. So medication for seizures will only work if they're being given. So if someone doesn't have their medication, then they will have a breakthrough seizure. So it's important that we educate people on the importance of giving the medications, and also what to do if it has been missed and how to make up for that missed medication. The other thing on medications is kids grow, so they have growth spurts. So their everyday medication may be maybe not at the optimal level for their weight. So sometimes they may have a breakthrough seizure also if they had a growth spurt because they've got a lower amount of their anti-seizure medication in them. Other common ones is also, especially in the area of disability, excitement can be a common trigger. So that could be, build up of activities. I'm just talking to a family that it's just all the things happening at once. So it might be, there's photos being taken for the day at school, and there's maybe a playground, and there's so many things happening. All those things building up could be part of the trigger. Even just a birthday or Christmas time, those sort of things can maybe be the trigger for their seizure. On the other side, it might be stress and anxiety. So it might be if they're being told off and they're very upset and something's happened. So that's why it's important that those sort of things are communicated as well from school, because it may be a trigger, but they may not even have their seizure till later on in the day. So it's good to know what's happened at school or happened during the day, so they can be prepared. I won't go through every single one, but menstruation and hormonal changes, 50% of girls or women, when they have their period, they actually have an increase in their seizure activity. So that's a big one there. And also pain can be a trigger for some people. Constipation, I suppose, a pain to do with constipation. And drugs and alcohol can be for some people too. But everyone's not the same. Actually, the biggest one I didn't talk about that probably you'll know about is photosensitivity. So often people know about this as a trigger, but only 5% of people have this as their trigger. And photosensitivity could be strobe lights for some people. For others, it could be going from a dark room to a light room. Others, it could be maybe flickering lights, the light through a fan that's going over near a light. That sort of thing can be enough photosensitivity for that person to have a seizure. So it's all very individual. As you know, epilepsy is very individual. Seizures are very individual for that person and their triggers as well. Okay, so we'll talk about the management of seizures. So the first line management is anti-seizure medication. They used to get called anti-epileptic medication, but they're actually working on the seizures. So they're trying to prevent seizures occurring. So firstly, it's important, as I said earlier, to work out what sort of seizures a person's actually having so they can determine what sort of medication to prescribe. And sometimes at the start, they might prescribe medications that are sort of general to both seizure types until they can work out which one that, whether that's enough control and whether they need to perhaps add any more. I'm not going to go into any details with all the medications that are available. There's many available, and everyone's so different in the reasons why they have certain medications and whether they work or not. But what is important is to try and get a really good diagnosis as to not only the types of seizures, potentially even the type of epilepsy that person has. Because there's some certain epilepsy syndromes that certain medications can make the seizures worse. So the more that we know about the diagnosis, then the better we can stay away from those medications. We also end up knowing what sort of ones to choose as well. The other thing is that not everybody can get good control with one medication. 70% of people can, but of the people that can't, they're considered to have drug-resistant epilepsy. So that means that person has tried 2 or more unsuccessful medications to try and get control of their seizures. So they're classified after just 2 unsuccessful attempts. So often a person will have more than one medication on board, and that means often there's more side effects as well that they're dealing with, and they're also having to deal with the interactivity of the medications on each other. Some can make others worse and others less effective. So and then they may also have other medications for their other comorbidities as well. So that can make it quite complicated. There are other options as well for medication. I'll go through that in a minute. But if you want more information about anti-seizure meds, the Royal Children's Hospital fact sheets are really good. They have a lot of information there as to the types of seizures and the types of medication to give for those. The last one I didn't actually talk about was emergency medication. So remember earlier I talked about prolonged seizures. So prolonged seizures for tonic-clonics are over 5 minutes. For over 10 minutes, that's the definition of a prolonged focal seizure. So some people would have been prescribed emergency medication to get early control of those seizures, because the earlier we can to act on stopping those seizures, and the outcomes are a lot better in stopping those. So you may have heard of midazolam. That's one of the medications you can use. It's the most common one. So the non-pharmacological treatments for seizures, firstly, again, important to know what the underlying cause is. So they would have had all the investigations to find out what the underlying cause is and where that seizure activity is coming from. So if we're able to find out where it's coming from, if it's a focal type epilepsy, for example, they might even be able to perform some surgery, and often surgery is better performed in childhood. The outcomes are better in childhood, so they can control that abnormal electrical activity. They can actually remove part of the brain, the abnormal part of the brain, or disconnect part of that brain that's where the seizures are coming from. So there's a lot of investigations that have to happen for that to occur, but evidence shows that getting that happening in the early stages in childhood is a better outcome than waiting for adulthood. And also you're preventing a lot of seizures by doing that too. The other surgical option is a VNS, that stands for vagal nerve stimulator, which is a device that can be surgically implanted. And it's a device that it's a bit like a pacemaker that sits under the skin here. The generator sits under the skin, and there's a lead that goes into the brain via the vagal nerve and produces a stimulus which disrupts abnormal electrical activity. So it's set at a certain setting to discharge this stimulus, and in background all the time, every say 3 minutes for 30 seconds is a common time for it to discharge, and that can disrupt abnormal activity, which might mean that the seizure is prevented, but if it's not prevented, it will stop it, and it might reduce also the recovery time as well. So that's a good option because there's no systemic side effects, so the person doesn't have another medication to deal with side effects. Other options is ketogenic diet. So that's both these diets, ketogenic and modified Atkins diet, very specific medical diets. They need to be very closely monitored. Ketogenic often starts in children. Modified Atkins is more in adults. But these diets, they affect the way that the brain metabolizes energy, really. And so there's evidence showing that these diets can change and produce better control on seizures. So it's very hard to stay on these diets. It's very restrictive and you have to be exact and measure everything. So, but it is an option, and there's a lot of support around for those diets too. And Rheana is one of those people that can support providing information about all these sort of things as well. Medicinal cannabis is another option. We actually consider it as another type of anti-seizure medication in a way that it potentially can work really well for a lot of people. For some people, it doesn't work. And some people, you can have side effects with the medication as well. So we'll just sort of put it in the mix of anti-seizure medications, but it is an option. So the last thing I'll talk about is epilepsy management plans. So I talk about them because that's a big part of what I talk about in my job, because it's really helpful to have an epilepsy management plan so others know outside the family how to give support to someone with epilepsy and understand their seizures and know what to do. So if you have a plan in place, and it's really helpful because firstly what they can do is look at on their plan you can have a space that has an area that would have information on how to identify any changes in that person in their behaviours that might alert them to a possible future seizure, like that build up, as I said, like they might get more aggressive or they might get very quiet, and those things. If it's on a plan, and that's an alert maybe to a carer so they can tell you about it, and that you've got the sort of alarm bells on for something later on in the day that may potentially happen. The plan will also have information on it about seizure triggers. So of course that's really important information for people that care for that person with epilepsy, so they can prevent those triggers if possible, or they can manage them. And they can also manage any potential risks, such as when they're around water. We should never leave anyone with epilepsy around water unsupervised, so we need to have instructions about that, and also for nighttime if they have nocturnal seizures. Also, there'll be information about the seizures themselves, what they look like and how to actually manage that person, because everybody's seizures are very specific for them and their management is very particular for them as well. And then not every time you need to actually call an ambulance. So we'll have indicated which seizures require an ambulance and when to call them as well. And then the last one is, it's really important, is for people to be able to identify when the seizure's actually finished. Some seizures are so subtle, it can be really hard to even tell. It might be just the little eyes flickering. Even with the eyes closed, you might have to open the eyelid and actually see what the eye's doing to even determine whether that seizure's finished. They can be very subtle. So being really prescriptive on your plan is important. So we've got that information so it can help others determine whether the seizure's finished and how to also provide this appropriate seizure support. Okay, so that's my my spiel, but I've got this last page here just to before I introduce Rheana, because Rheana's in here. She's nice and purple. Rheana and I were involved in Make March Purple last month, and that was to raise awareness for epilepsy, and so we were part of the slime challenge. So that's me on the left and Rheana on the right. So how's that for an introduction, Rheana?
Thanks, Kelly.
Okay.
All right. So you will get the opportunity to ask questions, and I'll make sure that I'm as brief as possible, because I do realise that it's later in the evening, and that it was the first day back at school, and after time off. So I'll just share my screen. Kel, if you could just give me a thumbs up, can you see that? Perfect. All right. So first of all, obviously, my name's Rheana and I'm a support worker at the Epilepsy Foundation. I'm actually a social worker, that's my background. And I've been at the foundation, I had a hiatus for a year, but I've been there since about 2018, I think. So yes. So let's get started so that we can kind of rush through my bit and you can ask questions. So I'm going to talk about the foundation and the teams that Kelly and myself belong to initially. And we're part of what's called the client services team. So we're the teams that provide the support to families like yourself, whether it be adults, children, adolescents, but carers and parents as well. So you have we have the new National Epilepsy Support Service, the NEST team. They're your first contact. And so when you ring, that's if you haven't actually been part of the foundation before, you'll actually go through the NEST line, and I'll explain that a little bit further on. The next level of support is with the Epilepsy Support Worker team, which I'm one of. We're a team of 9 led by an amazing practice leader called Monique. And most of us have a form of background in the disability sector or as social workers, psychologists, OTs. So we bring other elements to the team as well. And then, of course, you have the amazing education and training team, which Kelly is part of. And through her presentation, you've seen a lot of it actually of what they do in being able to provide training to families, disability workers, schools, businesses, if they also have people employed there that have a diagnosis of epilepsy, they can also work there. So the first team is the NEST team. They're the first point of contact. They can provide initial information to anybody who contacts them. Their intervention is very brief. However, they have the capacity to refer on to other teams like myself at the support worker team or to the education and training team. And that's part of their planning and goal setting when they speak to, say, one of yourselves, if you ring up. They'll talk through any issues or problems you might be having at that time, provide you with immediate information if they can, and that intermittent support. And if they feel that you need any further support or longer standing support, the referrals will be placed. And so the referral will come to us at the epilepsy support team, and you'll be allocated someone like myself, and I can work with you as short or as long as it is required by any of our clients. It's totally up to the client. It's very much about ensuring at a level of self-management, but also ensuring that you feel supported both from an emotional perspective, but also from, a medical and understanding about what it is to have a diagnosis. We can further expand on the information that you've been provided already by the NEST, or we may actually be able to provide you with new information that may not have been discussed in that initial intake. We can give advice about risk management and living well with epilepsy. Having a diagnosis of epilepsy, and I understand most of you have family or members of your family who have syndromes without names, so understand the complexities of these kind of diagnoses and being able to work with them. We provide individualised support for people living with epilepsy. As Kelly has already stated, we really focus on the person that we're dealing with in that space. So, when I'm working with a client, each client is very individual. Their families and supporters and carers are individual. The person with epilepsy is individual, and no story is the same. no epilepsy diagnosis is the same, no medication is the same. So like Kelly said, you could have 5 people standing in front of you and all of them have a diagnosis of, say, absent seizures, yet they may all be on very different medication, present very differently, have different behaviours or triggers, and have different cognitive impairments because of the diagnosis. So we have to really ensure that if I'm speaking to any of you, that I'm really focused, and our team's very focused on making sure that this is about your journey and your child's journey, or the person that you're living with or working with in their epilepsy journey. And finally, the education and training team. And I kind of ran out of room, but I just knew that Kelly was leading the charge this evening, and I thought there was very little to be said. But the team is made up of amazing nurses, fully registered, who have amazing knowledge around epilepsy or neurological disorders, have a vast level of experience in this area, and are really amazing at what they do. And not only do they educate around, you know, like what Kelly's just shown, that they also, you know, we work very closely as a team. So we kind of, if we've provided support, they ask different questions. So sometimes little things come out that may not have initially come out when working with support worker. And that's really, really important that those little bits of information are found. So they're the 3 teams. Although the NEST team works under the Epilepsy Smart Australia and is a national, I still have included it in the team within the foundation because they are an important part. Okay, now I'm guessing that people on this Zoom screen tonight, who I can't see anyone except for Kel at the moment, know more about NDS than probably I do. So I don't want to take that away, because I'm sure that there's more about NDIS that you could teach me than I could teach you. It's a very, very extremely complex process, and can cause quite a significant, I was going to say trauma, and it would be trauma, and, you know, going through all the processes to ensure you get all the best support you require. Unfortunately, epilepsy is defined by NDIS as part of it being part of the health system. However, if the diagnosis of epilepsy relates significantly to the syndrome, whether the syndrome has a name or not, and you can prove that, then they will fund. But it's kind of very limited, and that's kind of outlined in their guidelines in the link you can see there. And at the end of this, what I'll do is I'll send Heather all these links so that they can be, you can have a look at them if you haven't seen them before. So NDIS at the moment is only assisting with assistive technology such as monitors and alarms, and I'm going to speak about that soon. About disability or support workers or a nurse for people who have seizures that are not well managed due to medication or whatever, and may require ongoing 24/7 care. And then training of support workers for those that are, you know, getting actively back into the community, or maybe at a school, or within a workplace, a special development workplace, things like that. They will cover those. They no longer cover the development of epilepsy management plans, however. So it's very limited. It's very complex getting into the NDIS with epilepsy alone. But that, what I'm saying is that you should not try. I think it's really, really important that you build a really good framework around the epilepsy, and then alongside the disability that the person you have, your child or your family member has, and then working around that. You can always contact the foundation, and we can help you and assist you to work through some ideas and goal setting around some of the things that may best be suited when you put in your applications. I'm going to talk about a very difficult subject now. It's an uncomfortable subject for everyone. It's called sudden unexpected death in epilepsy, SUDEP. It happens, unfortunately, and it's something that everyone really needs to be aware of and to speak about. I'd just like to highlight the SUDEP action that you can see in the frame is actually based in the UK, but their website is amazing when it comes to the provision of information around SUDEP itself. As you can see there, nobody knows what causes SUDEP, and among children it's a very rare occurrence, as low as 1 in 4,500, and it's proven to be a risk lower in children than in adults. And just a few pointers here, how to reduce the risk, obviously is to have a discussion about SUDEP. You know, it's really important that we shouldn't be it's anxiety provoking. I'm a mother of an adolescent, or he's not an adolescent anymore, but of a child with epilepsy who's now into his 20s. And this is a discussion that I had to have with him. And I know that some of the families here tonight, you're in a position where you actually physically can't have that discussion with the person that you're caring for. However, that doesn't mean that you can't have the discussion with your family members, support workers, carers, etc. And just be aware of what some of the causes could be or triggers. It's about management really at this stage, about ensuring medication is taken correctly, good sleep, knowing what the triggers are, good routines, but also highlighting that it doesn't necessarily happen with people that have epilepsy, which we define as refractory, which means uncontrolled, or it can actually happen to people, unfortunately, that have very well controlled epilepsy, and it can just actually come out of the blue. So look, I know it's a difficult subject to discuss and even to read about, but I really feel strongly that it's something that we all across the board should educate ourselves on. All right. Monitors and alarms. So this is a really interesting subject because how we approach this is very much up to the individual. Having heard Professor Ingrid Scheffer speak on a number of occasions, she actually doesn't recommend any monitors or alarms, and she states, if anything, an oximeter is probably one of the best to get. And that's kind of, you probably all know, they stick them on your fingers, or babies, I think they stick them on their toes or where they're least moving. And what it does is it just monitors the breath and heart rate. So if the oxygen levels drop. Now, I have a client who has used this with her child and she swears by the oximeter. There's other people that use, as you can see here, this alarm set is called a SAMI 3. And then you have families that think this is amazing, okay? And then there's others that use the Apple iWatch where they think that that works really well. And also then you have the mattress, or sorry, underlay that sits in the mattress that can pick up tonic-clonic seizures. Interestingly enough, a majority of the alarms and monitors that are designed at this current time do not predict seizures and generally only pick up on convulsive type seizures. So that can be a little tricky if you have a child who's quite restless, because sometimes the alarms do just go off because they've moved, not necessarily because of the seizure itself. It's a very personal thing, the use of these alarms and monitors. And as a foundation and as a worker, I personally can't make recommendations. Neurologists generally don't make recommendations either. And as I said, they don't cover all types of seizures. So it's really about doing some really good research, seeing what you think will best suit yourselves or your families if you're going to use them. And I've got these links here that I'll share once again, and Heather can send out, which gives you that information. And if you ever want to discuss further, or you just give us a call and we'll be able to assist you, just in discussion. Also, there's a number of really amazing Facebook groups where the parents have discussed, and all of them, if you type in SAMI3, these hundreds of posts will come up where people have used them and give really good examples. And I think sometimes that's the best way to find out if it's what would suit you, is to ask in that peer group area there. But I'm happy to answer any questions after this, if you have them. We're nearly at the end, so you'll be able to break for coffee soon. The foundation isn't just about support. One of the big things it's about is also research. We have the Australian Epilepsy Research Register, and this is a database that you can also belong to. And it's more about us working and looking at the social and psychological research. So it's more that you wouldn't be part of any clinical trials, etc., but your information you'll receive, surveys to complete, and this is done over a significant period of time. And that information is then collated so that a better picture can be built over time around differing, supports that may be required, or even research that needs to be done moving forward. And we do have the Australian Epilepsy Research Fund, which is a really weird acronym, and I always think of the Nerf guns when I see that bit. So the project is funded, and then what happens is researchers put through ideas about what they would like their money for, so that they can specifically research. It goes in front of a number of people and their papers are read. It takes a significant period of time for decisions to be made, because it's going to be over a long period of time for most of them, anywhere from 2 to 5 years. It's a considerable amount of funds. And then they're chosen to ensure that there's no repetition, and that, the best they can, that all epilepsy areas are being covered, specifically not just, within the focal or the generalised area, but also in the genetic area. As you can see here, I've named 2 of a number, and which can be found at the projects funded, and I can put that link if you're interested as well. So both of these, one is actually Professor Ingrid Shefford and one is Dr. Mayim Zoghi, and you can see they're very different about what they're looking at, because they all have their expertise. But if you're interested, I suggest that you go to the link once it's posted, and then we can provide further information as required. So from me, that is it. Thank you for your time this evening. I'm just wondering if anyone's got any questions of Kelly or myself.